Hello and welcome. My name is Anita Fitzgerald. I'm an assistant professor in the School of Nursing at California State University. And today I wanted to talk to you about implicit bias. The objectives for our presentation today are that you will be able to define implicit bias, differentiate implicit bias from explicit bias, describe implicit associations, implicit stereotypes, and implicit prejudice. Explain the effects of implicit bias in maternal health care. Understand the connection between implicit bias with healthcare disparities. And identify countermeasures to implicit bias. So let's begin. An implicit bias is an automatic cognitive evaluation. It evolves from cognitive shortcuts that help us make sense of the millions of pieces of information we encounter every minute. These mental shortcuts enable quick and efficient decision making. They can be harmless and helpful, but taking one of these shortcuts inaccurately could lead to implicit bias. The more stressed we are, or the more quickly we need to come to a decision, leads to more reliance on shortcuts and a greater risk of implicit bias. For example, when I say preeclampsia, who is the patient that comes to mind? Are they Black or white or Asian? How likely is this patient to understand what's going on? Do you expect them to agree with the treatment plan? Give some thought to what immediately came to mind. There's no judgment, just an awareness of our thinking. Unconscious biases apply to things and events as well as to people. They can lead to a negative evaluation of a person on the basis of irrelevant characteristics such as race or gender. They rely on stored information about a group of persons and reading signals. Our brains tend to look for patterns and associations, to seek out and recognize what distinguishes something from other things. Unconsciously, we place values on those associations. What is similar to me is good, what is dissimilar is bad. Recognizing what sets one apart from others and then forming negative opinions about those who are different or social groups with which one does not identify contributes to the development of implicit biases. Implicit biases are pervasive. Everybody has them. And these implicit associations do not necessarily align with our declared beliefs or reflect attitudes we would explicitly endorse. Because we are unaware of them, we do not overtly affect them. Implicit biases are unconscious and based on experiences in the world. They are fed by personal experiences, translated experiences, such as the stories we're told about our families, and societal cues. Influences from experiences contribute to implicit biases, whether personally experienced or experienced through media, culture, or upbringing. The way TV or movies portray individuals or the language used in a newspaper or magazine can ingrain biases in our mind. This can be assigning attributes through repeated images, such as women are nurses and men are doctors, white people are professionals, or Black people as drug dealers. School, friends, relatives, and the culture in which one grew up can embed these ideas without conscious recognition. And the way one was raised can also play an important role. This includes the neighborhood one grew up in, the kids they played with as a child, the type of person one encountered based on who lives nearby. And this doesn't just happen when developing. These types of exposures continue to influence the associations we make as adults. So let's talk about explicit versus implicit biases. Explicit biases are known. They are judgments we are aware of, even if we choose to conceal them for the purpose of social or political correctness. We can think about how they developed, and we can correct them through introspection. Implicit biases reside deep in the subconscious. These biases are not accessible through introspection. They are unconscious and uncontrollable. We cannot correct them until we know they are there. Biases are deviations from the norm. They are based on associations and assumptions, not facts. There are a variety of implicit biases. Implicit associations are simply that, associations. They are not inherently good or bad. They are what I talked about at the beginning, those connections we make without realizing them. They can help us understand a patient need based on something similar we have seen with another patient. However, they can be misleading if they deviate from the truth. Implicit stereotypes are based on a trait associated with a group or category. Women are emotional, or gay men are effeminate. They cannot be based in fact because they overgeneralize to all members of that group. Another more dangerous type of implicit bias is implicit prejudice. This is a negative evaluation based on a trait such as race. In other words, having an automatic preference for one race over another without even being aware of this bias. Examples may include a person holding an implicit prejudice that associates Black individuals as violent and as a result crosses the street at night when a Black man walks in their direction, even without realizing why they're crossing the street. Another example is if a Latino student is complimented by a teacher for speaking perfect English, but he's actually a native English speaker. Here the teacher assumed that simply because he's Latino, that English would not be his first language. As in the examples just given, it is the behavior driven by these unconscious biases that cause the harm, not the explicit beliefs the person has. This explains why there can be a disassociation between what a person believes, that all people should be treated equally, and what a person does, communicate a derogatory insult. We can consciously reject the negative ideas associated with certain groups, yet we are all immersed in the same culture, where outgroups are constantly depicted in pejorative ways. Microaggressions. The actions I just described are examples of microaggressions. A microaggression is a subtle, automatic, verbal or nonverbal action that communicates hostile, derogatory, or negative prejudicial insult toward another group, often done without conscious awareness. Microassaults are verbal or nonverbal acts that imply the person is of lesser worth. For example, using an ethnic slur or clutching one's handbag in the presence of certain individuals. Micro insults are messages that are insensitive and disparaging, directed to a person's racial identity or background, such as implying that a racial minority did not earn their position. Micro invalidations are behaviors that negate, neutralize, or deny the experiences of people of color. For example, racially insensitive comments such as, "I don't see color," or "we are all the same." Cruz et al. Developed the Microaggressions in Healthcare scale, which can be used to assess and monitor racial and cultural forces that shape patient-provider interactions. Their research found that racial microaggressions in healthcare correlated with depression and anxiety, as well as with psychological stress. They describe microaggressions in healthcare as, quote, implicit discrimination within the healthcare setting, whereby treatment providers who are in positions of authority inadvertently marginalize members of minority groups through culturally insensitive interactions, end quote. Healthcare microaggressions stem from a situation in which those in the dominant culture, often in positions of power, deny their prejudices and hold to a self-belief that they treat all people as equal. This is particularly harmful in healthcare, where healthcare providers hold a position of authority and patients are in a vulnerable state when seeking treatment. There's also an institutional factor, which reflects systemic organizational practices that fail to respond to discrimination and microaggressions appropriately, such as with policies or procedures that enforce accountability. The result is a normalization of culturally insensitive interactions. All this can undermine patient-centered care by limiting the chance for a positive relationship to take place. Patients of color then feel less supported and at times discriminated against, and are more likely to fail to follow up on recommended treatments. There is the potential to improve individual interactions and system-level inequities through reflective practice and a conscious appreciation of individual differences. It starts by acknowledging your position of authority and privilege. It continues with a reflective practice in which you explore an experience you had to identify what happened and what was your role in this experience. This includes your behavior, thoughts, and emotions. It allows you to consider changes to your approach in similar situations to come. Implicit bias and the resulting microaggressions cannot be measured with self-report surveys because they're unconscious thoughts and actions. There are, however, tests that can get at the unconscious thoughts with some reliability. The implicit association test, or IAT, is the most common measurement used. In the IAT, respondents are asked to sort words or pictures into groups using keys on a computer keyboard. The groupings represent two concept dimensions, race and evaluation. The strength of association between concepts is determined by the respondent's speed in sorting the items, with faster responses indicating a stronger association. Most white respondents, for example, are significantly faster when the black and bad items require the same response, and the white and good items require another response, compared to when black and good responses are the same and white and bad responses are the same. The larger the performance difference, the stronger the implicit association or bias for a particular person. If you'd like to take the test, it is publicly available at this Harvard URL. Another test is the assumption method. It involves measuring differences across participants in response to clinical vignettes, which are identical except for one feature, such as the race of the character in the vignette. There's no direct measure of the implicitness of the participants' thought processes. Instead, there is an assumption that most people are explicitly motivated to disregard factors such as race. If there is a statistically significant difference in the diagnosis or treatment prescribed correlated with, for example, the race of the patient, the researchers infer that this is partly a result of implicit processes in the person's decision-making. Implicit biases are present in any situation, including healthcare. A variety of studies conducted in various countries using different methods and testing different patient characteristics found evidence of implicit biases among healthcare professionals. The biases of most concern are those that disadvantage those that are already vulnerable. Examples include racial and ethnic minorities, immigrants, the poor, low health literacy individuals, sexual minorities, children, women, the elderly, those with mental illnesses, the overweight, and the disabled. But anyone may be vulnerable given a certain context. These studies have shown that the greater the level of implicit bias, the lower the quality of care. Racial and ethnic minorities and women are subject to less accurate diagnoses, fewer treatment options, less pain management, and worse clinical outcomes. Some biases may be included in the training of healthcare professionals. Pattern recognition is frequently taught to form and narrow a differential diagnosis. Narrowing down the condition a patient presents with includes ruling out conditions not associated with that racial or ethnic group. This is not to say that group characteristics are not important. However, this blanket approach tends to support implicit bias. Biases in healthcare are influenced by health disparities. Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristic historically linked to discrimination or exclusion. Implicit bias is directly linked to health disparities. The unconscious assumptions affect what symptoms are acknowledged or ignored, what treatments are offered or withheld, and the results are detrimental. Pregnancy-related mortality is 3 to 4 times higher among Black women than white women, even when education and socioeconomic status are taken into consideration. Black women are more likely to experience postpartum hemorrhage and peripartum infection than all other ethnic groups, and are more likely to die as a result. And the detrimental effects are not limited to Black Americans. Alaskan Natives were 2.5 times more likely to have a pregnancy-related complication. It's important to distinguish between disparities in health conditions and outcomes. For example, the presence of uterine fibroids or maternal mortality is a disparity in a health condition. This is different from disparities in healthcare services, such as whether a patient receives early prenatal care or not. They are different problems with different solutions. Receipt of early prenatal care can be seen as an example. Black women have lower rates of prenatal care than white women, and white women are more likely to benefit from receiving prenatal care. In one study, the reduction in maternal death associated with receipt of prenatal care was greater for white women than that observed for Black women during the same time period. Black mothers tend to suffer from inadequate prenatal care. Only 79% of Black women get prenatal care during the first trimester of pregnancy, as opposed to 89% of white women. Around 79% of white women are provided with prenatal care that is at least adequate. Only 69% of Black women receive at least adequate care. 32% of Black women do not receive the recommended number of prenatal visits. This is compared to 25% of women of other races. Patient-level factors do not completely explain the disparities in healthcare outcomes. Some of this comes from clinical decisions, which are positively or negatively influenced by subconscious perceptions about patient characteristics such as race, ethnicity, body habitus, sexual identity, and others. Another example of disparity can be found in rates and treatments of gestational diabetes. Women of color are up to 2 times more likely than white women to have gestational diabetes. Those with both gestational diabetes and obesity have reported concern that expectations set by their healthcare provider were unrealistic, and they often felt stigmatized by their healthcare provider due to being obese and being diagnosed with gestational diabetes. Other concerns voiced include communication barriers and concern about the quality of healthcare available to them. A racially and ethnically focused gestational diabetes management program that is woman-centered could serve to lessen the disparity. Such a program would center on patient engagement, education, and focus on the unique social, financial, and medical concerns and situation of each patient. Racial disparities can arise for different reasons. There are patient-level factors such as patient preference, attitudes, and adherence to treatment plan. But there are also the effects of the experience of racism, life stressors, and cultural mistrust. And when there's a cultural and language mismatch between patient and provider. Then there are healthcare system level factors, such as access to care and availability of care. Where clinics are located, how easy it is to enroll with a clinic, play a big role in whether or not care is equally provided. Practitioner level factors include the effects of implicit bias on recognition of symptoms and recommendations for care. For example, racial and ethnic minorities may be less likely to undergo prenatal genetic screening. This is influenced by how readily it is considered for a particular patient and by differences in value placed on the information obtained from such testing. And there are historical legacies that play a role. Black people have a right to be suspicious of an institution that has historically victimized their ancestors for centuries. The idea of Black slaves as chattel, owned by another, meant enslaved Black women who bore children would be building up capital for their enslavers. This led to experimentation and inhumane surgeries forced on Black women in an attempt to save their children for use as future farmhands. Dr. James Marion Sims, known as the father of modern gynecology, has a controversial legacy. He's known for inventing the Sims speculum, Sims sigmoid catheter, and the Sims position. He was also known for developing the technique for repair of vesicovaginal fistula, a complication of childbirth. He perfected his technique on enslaved Black women without the use of anesthesia and without consent. Sims declared that the enslaved Black women were willing and had no better option. Another example is Dr. George Otto Gay. He was a researcher at Johns Hopkins in the 1940s, and he collected cancer cells from patients without their consent. The most famous of these were from Henrietta Lack, which have come to be known as HeLa cells. These cells have been used widely for discoveries in many fields, including cancer, immunology, and infectious disease, and most recently in COVID-19 research, all without the knowledge of Henrietta Lacks, who died in 1951, or her family. None of the biotechnology or other companies that profited from her cells passed any money back to her family. Calls continue for an end to the use of these cells because they were obtained without her knowledge or consent, saying any use of them is unethical and unjust. More recently, there was great controversy over the uses of the contraceptive Norplant. When the Norplant was first introduced in the 1990s, judges and legislators in several states attempted to mandate its use by certain groups of women. Those convicted of child abuse or drug use during pregnancy were given a choice between having the device implanted or going to jail. Legislation in some states would have required women receiving public benefits to use Norplant or lose their benefits. There was backlash from those stating these women, most of them women of color, were not in a position to reject the choice. Many called these mandates or so-called choices unconstitutional and a violation of a woman's reproductive autonomy and body integrity. Probably the most widely known of Black America's historical legacy in healthcare is the Tuskegee experiment. In 1932, 600 men were enrolled in a study run by the U.S. Public Health Service. Enrollees were purposefully injected with syphilis and not given any treatment to study the effects of the disease. The participants were primarily sharecroppers, and many had never before visited a doctor. The men were given placebo treatments, even when penicillin became the recommended treatment for syphilis in 1947. Many of the men died, went blind, experienced neurological deterioration, or experienced other severe health problems due to their untreated syphilis. It was not until the 1960s that an investigator named Peter Buxton found out about the Tuskegee study and expressed his concerns to his superiors that it was unethical. The Public Health Service chose to continue the study until all the men experienced full symptoms or died and their data could be analyzed. Buxton then went to the media, prompting public outrage and forcing the study to shut down. By that time, 128 participants had died. At least 40 spouses had been diagnosed with syphilis, and the disease had been passed to 19 children at birth. Examples such as these persist, although in much smaller numbers. One that was recently in the headlines was the experience of Serena Williams when she had her baby by C-section. The day after the delivery, Serena suddenly became short of breath. Because she has a history of blood clots and had been off her anticoagulant due to the C-section, she immediately assumed she was having another pulmonary embolism. She told the nurse she needed a CT scan with contrast and IV heparin right away. The nurse dismissed her request, attributing it to the pain medication Serena was on. But she did get the doctor to order a Doppler study of her legs. Serena was frustrated by not being listened to by hospital staff. When they did get the CT scan of her chest, they found multiple small clots and started the heparin drip. If it can happen to someone so famous and credible, many responded, it for sure is happening every day to others. Such experiences have contributed to widespread mistrust of the healthcare system by Black Americans and a belief that there is something to hide, particularly when seeking consent. The result is that many Black Americans are reluctant to seek care, distrustful when they do seek care, and unwilling to participate in clinical trials. All this is compounded by a lack of racial and ethnic minorities in all areas of healthcare. Such mistrust may have its origins in historical events, but they are compounded by current encounters. In research cited by Scharf et al., ethnic minority patients receive less information, empathy, and attention from their physicians than their white counterparts. And African American patients are less likely to receive medical services than white patients with similar complaints and symptoms. But there are countermeasures. Implicit biases are malleable. Our brains are incredibly complex, and the implicit associations that we have formed can be gradually unlearned through a variety of debiasing techniques. It is a process of retraining those implicit connections to new, less damaging ones. The first countermeasure is to change our mindset to one of humility and openness. When we shed ourselves of the idea that we already understand a person, our minds open up to learning new things. This mindset also includes a motivation to be fair, a conscious approach to considering more than one way of looking at something. Decoupling is breaking the causal link in an association. This also takes conscious thought. For example, a person who finds herself wanting to cross the street when approaching a young Black man can actively ask herself, is there something overt in this situation that's causing my fear? What is it about this person individually that makes me want to cross the street? Where did these ideas come from? Debiasing involves retraining oneself and making overt our unconscious thinking. This involves actively looking for countertypical examples, becoming aware of people, in person or in the media, that are different from what we would expect. It involves actively resisting those images and ideas that come to mind surrounding a specific group of people. And stereotype replacement, which I'll explain more fully on the next slide. Stereotype replacement is a conscious process to shed an implicit association and replace it with a more fair and open connection. The first step is recognizing when thinking seems driven by stereotype. This includes being aware when we are making an assumption about another person. The next step is to label that thinking as biased and then reflect on why it occurred. Why did I assume that about this person? Where did that thinking come from? Was it from this person individually? After reflection, then replace that thought with a counterexample. This helps to remind oneself that there are many expressions of that group of persons. And there are individual steps a healthcare provider can take to combat implicit assumptions and biases. Understand and respect the magnitude of unconscious bias. Develop an understanding of the cultures from which your patients come. See each patient as an individual to avoid stereotyping, and become familiar with the national standards for culturally and linguistically appropriate services in health and healthcare, also known as the National Class Standards. Within the healthcare community, these same measures can be exercised as a group. This will take effort and at times courage, as there will be resistance. The first countermeasure is to communicate, to have the tough conversations with your coworkers. It can start with something like, I'm concerned about the lack of diversity in our unit. What do you think about this? Or, I believe you just made an assumption. What led you to believe this patient would have high blood pressure, for example? These conversations can be difficult, but without them, we're left to make our own assumptions about our coworkers. Another is to increase your health equity knowledge. What do health statistics say about the patients you treat? What are the real numbers in your community? There are many websites that share information and best practices about implicit biases, and you can share them with your coworkers as well. Advocate for more diversity on staff. This will increase the number of viewpoints that get heard, as well as give patients the opportunity to see healthcare workers they feel they can connect with. Look at your practice from the perspective of your patients. This can involve having conversations with patients about what they see as beneficial and what changes they would make. How comfortable is it to bring things up without being asked? See the unit with fresh eyes, as if you were going to receive care there. And speak up when you hear assumptions being made or generalizations about patients. In the larger healthcare system, there are countermeasures as well. Recognizing and addressing unconscious bias is the first step. Consider the use of the implicit association test to identify individual biases. Encourage individuals to ask if a decision is being made based on a bias or a stereotype. Educate workers about unconscious bias through training programs. Establishing a diverse and inclusive healthcare culture. Remember, it's not enough just to have diverse voices. These voices have to be heard. Define a non-retaliatory system for reporting and responding to unconscious bias or discrimination. Create diverse teams. Provide comprehensive services for diverse patient populations. Standardize the hiring and evaluation process. Set clear objective criteria for employee evaluations and use blind evaluations and applications whenever possible. Evaluate the process and the evaluators. And measure outcomes, including reported instances of discrimination and bias in employee hiring, pay, promotion, and retention. Measure patient outcomes, such as maternal morbidity and mortality. Assess employee perceptions of inclusion, discrimination, and fairness. The legacy of implicit bias negatively affects healthcare providers as well. Perceived discrimination and bias contribute to dissatisfaction in the workplace. Moreover, discrimination in the workplace directly contributes to poorer care provided. A solution comes from diversity in the workplace, diversity in traits such as race or ethnicity, and diversity in experiences such as working in another country or with another culture. But diversity alone is not enough. We also need inclusion to bring about results. Inclusion involves fairness and respect for all employees, creating a place of feeling valued and belonging. Inclusion also involves all employees being well tolerated and people being able to be themselves openly. It is a workplace where all are empowered and growing. It is a speak up and be heard culture. When interacting with patients, there are measures to counteract implicit bias as well. Spend quality time with your patients. This may mean longer visits whenever possible, maintaining eye contact, and using reflective listening. Relationship building can be invaluable, not just for that patient-nurse encounter, but for decoupling and creating countertypical examples. Get to know the person as an individual. Value that patient's experience. And create partnerships in decision-making with your patients. Honor their stories and lived experiences. Provide information and support them to make their own healthcare decisions, ensuring they are consenting as an informed decision maker. In the medical field, diversity and inclusion leads to improved health outcomes and increased access to healthcare by the underserved. However, unconscious bias may be inadvertently thwarted by this process and negatively affect patient outcomes and employee experiences in the workplace. Recognition of unconscious bias and targeted approaches to addressing its effect on patient care and the workplace may improve the overall culture. Moreover, defining objective, measurable outcomes is essential to addressing unconscious bias and sustaining a diverse and inclusive culture. Thank you, and that ends our presentation on implicit bias.